Morning, everybody. Welcome to SURSAC this morning. Got a few disclaimers to go ahead and knock out. This meeting is being recorded and live streamed on TVW. This meeting will be shared on the new SURSAC page. This recording is open to public disclosure. Please do not disclose any private or confidential information. Guidelines for public feedback. There will be 10 minutes at the beginning of the meeting and 10 more minutes near the end of the meeting reserved for public comment. Each person will have 3 minutes to provide feedback. If you are not a committee member and would like to make a comment during a particular discussion, please raise your hand for facilitator awareness and public comment on the topic. Will be invited before moving on to the next item. Feedback that is not provided during the meeting can be submitted via email at any time to hca5476@hca.wa.gov. I'm going to go ahead and go into attendance now. Michael Langer.
Good morning. Present.
Amber Leaders. This person will most likely be out. Senator Manka Dingray. Senator John Braun. Representative Lauren Davis.
Good morning.
Representative Dan Griffey. Caleb said he was going to be out today, but I just want to make sure that I'm calling his name. Caleb Banta Green. Don Julian Saucer.
Good morning.
Sean Meyer.
Yeah, good morning. Present.
Alexa Orr. Amber Coop. Oh,
It's Cope. Yeah, I'm here.
I did walk into a restaurant.
Morning.
I didn't walk in.
Brandy Flood.
Here. Good morning.
Stormy Howe.
Present. Good morning.
Chad Enright. John Hayden. Nikki Lewis.
Present. Good morning.
Morning. Harry Candelero.
Hello. Good morning.
Morning. James Tillett.
Present.
Christina Lynch.
Good morning.
This person will most likely be out, but I just want to say her name just to make sure if she didn't make it. Sarah Gillard. Donnell Tanksley. Malika Lamont. Addie Adwell.
Good morning, present.
Morning. Kevin Ballard.
Morning, present.
Hunter McKim. Representative Jamila Taylor. And Representative Gina Mossbroker.
Hi, good morning. This is Rep Mossbroker. I'm standing in for Dan Griffey today. Happy to be here.
Thank you. Morning. I'll go ahead and hand it off to Michael for announcements.
Right. First of all, thank you, Kelly. I'm not sure if you introduced yourself at the beginning or not, but
Oh, yeah.
Kelly Sandecker, he is our lead staff person for the SURSAC committee now. So I think it's your second meeting maybe now.
Yeah.
There. So thank you for going through that. Again, for those of you I haven't met, my name is Michael Langer. I am the Deputy Director with the Division of Behavioral Health and Recovery, and have been chairing the SURSAC since its inception. Want to welcome everybody here on a May morning. What we understand is this rain's going to turn to heat here in a couple of days, so hopefully everybody has a great week and enjoys the sunshine when it gets here. We know we have quite a bit of work ahead to share with you here this morning on some of the subcommittee work we're going to go over and some of the project work that you've asked to have updates on. So look forward to a good meeting here today. Just wanted to go through a few updates and welcomes. So first of all, we have Sean Meyer, and Sean and I and Kelly had a chance to talk a couple of weeks ago. I've really enjoyed getting to know Sean a little bit. He is our newest member. And Sean, if you wouldn't mind just sharing a little bit about yourself with the committee and your interest in serving on SURSAC.
Good morning, everyone. Yeah, like I said, my name is Sean Meir. It's spelt Meyer, pronounced Meir. I will answer to either or. My pronouns are he and him. I'm a CPC for Concord. I work remotely. Concord is based out of Monroe, Washington. I'm out here in Stevens County. I work in the local Stevens County jail as a peer counselor and work with the opioid people suffering with opioid use disorder. We have a MAUD program there. And then it's our hopes that they contact me or us, our organization, upon their release. And then we follow them into the community and support them with whatever they need and kind of meet them where they're at. It hasn't been real successful yet, but we're working on that. There's not a lot of housing out here for individuals, as you all know. Other than that, my passion comes from serving 16 years in prison out of a 24-year sentence. I got granted early release by the governor. He commuted my sentence after doing 16. I got released in 2018. Got the support I needed from my family and my current wife, who was just a friend at the time. And a year and a half ago, I did my CPC class and found this job. And my passion is helping the individuals coming out. I started a group. It's called Our Yard. It's for originally it was going to be for previously incarcerated individuals. We have it started here in Stevens County in Colville with one of the local doctors. He allowed me to use some space in the back of one of his clinics. That's slow going as well. However, we are in a rural community, so everything is slow going anyhow. So in a nutshell, that's me. I'm real excited about this committee, about having the opportunity to be a part of it, as you have a whole lot of experience in this system. And I was a drug addict since 12 years old until I went to prison at 32. So that's 20 years of addiction. I've got 22 years of sobriety under my belt. June 26 will be 22 years. And yeah, I think that's about enough. I don't want to take too much more time. Thank you for having me.
Sean, thank you for putting your name in for consideration for the committee. And I know our colleagues here at DBHR and Healthcare Authority are anxious to learn more from you. And I'm sure the rest of the committee members are as well. So really pleased that you decided to join us. Happy about that. Thank you. A couple other updates. We have, you had asked that we have a presentation by the Department of Children, Youth and Family on Senate Bill number 6109. And we have reached out to them, and that is scheduled for July. So we have to wait a couple months here, but in July, we will have a presentation about the bill's implementation over at DCYF. You had also asked for an update on the Icelandic model, which was one of the many investments that came out of the 24 legislative session. And this is a model prevention model that started over in Iceland. It has kind of found its way around the globe. And I know many of our tribes are interested in it, and we have 5 tribes that will be piloting this as the foundation. They have a different name for what they'll call their initiative, but it will be built on the Icelandic model. And we're working on a time and day to have that presentation as well. And then lastly, well, a couple things. I also just want us to remember as we're in May here, just a lot of appreciation for those that serve people in need, whether it's a prevention specialist or outreach workers, recovery navigator program or other outreach programs, housing, treatment, recovery supports. Just really keep in mind and offer support to those workers. We know they're still strained with workforce shortages, and we just appreciate so much what they do day in and day out. And many of them are you. So thank you for your work in this field. And I'd be remiss if not asking for thoughts also for the families and the individuals impacted by substance use disorder. We really want to keep the families in the forefront of our work here as this committee. So appreciate that. And finally, I also want to let the group know today, I think some of you are aware, but I have made a decision to retire next month. And so this will be my last SURSAC committee to chair. And I've learned just a great deal from you all and really appreciate how much energy and passion and intelligence that you bring to these meetings and lived experience. And it just has made us grow as a division and me as a leader. So thank you so much for all that you contribute. Going forward, we have Sarah is going to lead us. Melvin Klein is going to lead our meeting here next month with Kelly, and then Tony Walton and I will be on the other coast for a brief period of time. So we'll have Sarah sit in, and then we will keep you apprised. We do have some recruitments out for our division. There will be 2 deputies that will be posted. One's posted now, the deputy for treatment and recovery support services. And then we have a deputy that will be posted for prevention and children's programs and opioids. That will come out soon, as well as the operation deputy. So we are going through some leadership changes. I think we mentioned to this group last time that Tisha Kirschbaum is our new director, and we're thrilled with her bringing her experience and leadership skills to that position. And within the next couple of months, we'll have our full leadership team solidified. So bear with us. We'll keep you in the loop. And again, I just appreciate I've appreciated getting to know you all, and look forward to tracking how this committee works in the future and all the great things that will come about. So thank you. At this point, I'm going to turn it over to Blake Ellison, who has been doing a great job facilitating these meetings and helping us out for going on a couple of years now, Blake. So Blake, the floor is yours.
Thank you, Michael. Appreciate you. Gonna miss you. Thank you.
Okay. Hey, Blake, it looks like we have a question real quickly from Representative Lauren Davis before we get into the question.
Yeah, Rep Davis, please.
Oh, thank you. It's actually not a question, but a point of personal privilege. Michael, I just want to take a moment to thank you for your extraordinary service to the state over nearly 4 decades. I've joked with you before that you started with the state the year that I was born in 1986. It was a great year. But I think about just the work of your hands and the fingerprints on all the programs you've touched over that time period, and everything from your passion for prevention and your incredible investments in CPWI to your work in treatment and recovery services. It's just been extraordinary, and our state is miles ahead of where we were 37 years ago because of you. And I'm so grateful for all that you've poured out and for sticking with it for so long, and we're going to miss you very much.
Thank you, Lauren. Really appreciate that. Appreciate your leadership as well. But yeah, we got a lot of fun together. Thank you. All right.
Thank you. Okay, it is time for public comments. If a member of the public would like to make a comment, please go ahead and raise your hand and virtually, and I will call on you to make that comment. So again, time for public comment. please raise your hand. Again, we have this time allotted for any public comments. So again, please raise your hand if you'd like to make a comment. All right. I do not see any hands raised. So last call for public comment. Okay. Moving on, any walk-on items, those items that we possibly could fit at the end of the agenda. Does anybody want to add an item to the agenda that possibly we could cover at the end? If you do, please, again, raise your hand. Appreciate it. Any walk-on items, anything that we want to add to the agenda? All right, James.
Would it be possible to share like an event that is happening locally in our community that is relevant to the work that the SURSAC committee does at the end of the event or at the end of the meeting?
We're getting
Does that sound?
Yeah, please.
We got it, James. Yeah, that's great. Thank you.
Thank you.
Okay, anybody else? Anybody else have additional items? All right, then. It looks like Sarah and Tim are up to talk about health engagement hubs. So we'll go ahead and let them do that. Thank you.
Slide deck. Ready to talk about it. We're just pulling up our slide decks, everyone. Apologies
I
for
can
the
go
delay.
ahead and share it.
Well, that's being pulled up. I will make another comment since I'll take the liberty this being my last meeting. Last week, we had a report that come in regularly from the Recovery Navigator program. And each of the counties give a little snippet about a success story that they've had. And so I had a chance to go over those this weekend. And it is really warming to read how well that initiative that you all have been involved in helping think through and develop, how much great work is happening across the state. I know there's still room to grow and to get into more communities and to reach more lives, but those that are being reached, it is really cool to read the stories of progress that individuals are making and how grateful and thankful they are in some of their own words as they give back and tell their stories. So I wanted to share that while we transition in, and it looks like we're ready. Is that right? Okay, let's go ahead and kick it off.
Sure. Hi, everybody. My name is Sarah Melfi-Klein. If you haven't met, I supervise the Criminal Legal Systems and Blake Projects Unit with the Division of Behavioral Health and Recovery at the Healthcare Authority. And so kind of in that purview is health engagement hubs, among many other Blake-related recommendations and programs. So, and I'll pass it off to Tim to introduce himself as well.
Morning, everyone. For folks that don't know me, my name is Tim Candela. I use he, him pronouns, and I am the Drug User Health Harm Reduction Advisor for the Washington State Department of Health. And I support various activities over at our sister agency, the Healthcare Authority, where I'm sitting at right now, in addition to harm reduction efforts internally at the Office of Infectious Disease by way of supporting syringe service programs at DOH. So today we are going to give you all an update on health engagement hubs. There's a lot of history behind this program and a lot of work that has been happening since it was codified into law. So next slide, please. So as I said, there's a lot of history behind this. So the Health Engagement Hub is a concept that has been built upon previous models of care. So we're talking about bringing low barrier buprenorphine to individuals who are living with opioid use disorder and also care navigation services within low barrier settings such as service programs. These are activities that have been happening within low barrier settings such as syringe service programs in Washington State for over 6 to 8 years right now. In addition, there are other models like New York State has health engagement hubs, which are really focused on providing low barrier buprenorphine, as noted here. And so really health engagement hubs are built upon these previous models of care. So some of the other history behind it is this was a recommendation that was developed in the State Opioid Overdose Response Work Group number 3, which put forth the recommendation to the executive sponsors to use opioid abatement dollars to build out a health engagement hub model. And then in addition to that, more relevant to this group of folks, this model was designed and born out of the SURSAC treatment subcommittee, which occurred, I believe, in the summer of 2021. And so they developed a very broad range of services to be provided in a low barrier setting to people who use drugs. So there were multiple committees involved in the development of this. And ultimately, it was put forth as recommendations within the SURS plan by all of you on this call, and also recommended by the Goal 3 opioid work group. Next slide.
Great. So the 2023 legislative session, and specifically engrossed second substitute Senate Bill 5536, codified health engagement hubs into law as RCW 7124-112. It used language and design that was recommended by this committee. So the SURS plan presented a 2-page proposal that had to be developed into a comprehensive program. HCA was appropriated approximately $2 million, I should say, each for 2 pilot sites over 2 years, so $4 million total for 2 years to stand up 2 pilot sites, one in an urban area and one in a rural area. And the language at the bottom of the slide is just the language that is in the RCW that speaks to the 2 pilot programs that needed to be established, what's involved in them, and again, that they're meant to be an all-in-one location where people who use drugs can access a range of services, including medical, harm reduction, treatment, and social services, all under the same roof as much as possible, or through warm handoffs.
So how did we kick this off? We released a request for interest back in November of 2023. DOH and HCA did this in partnership. I think we kept the RFI open for about 4 to 5 weeks, and we received a total of 15 responses, which we were delighted to see. This is a very robust program, and there was some expressed concern, but expressed excitement. And that, I think, is reflected with the total number of responses. In addition to that, we received a wide array of responses from various programs. On that slide, we received responses from syringe service programs, opioid treatment programs, tribal health programs, in addition to federally qualified health centers. So we were very excited to see these responses and the diverse array of entities that were responding. Next slide.
So I'm excited to share about contracts underway with our inaugural urban site, which is Health Point in Auburn, South King County. Health Point is a federally qualified health center, and they submitted their response to our request for interest with a dedicated partnership with a local OTP, opioid treatment program, We Care Daily Clinic. This is an OTP owned and operated by Muckleshoot Tribe. And so while Health Point is a more traditional healthcare setting, their approach to serving health engagement hubs participants is based heavily in outreach, support, and building connection outside of clinic walls. And then within the clinic where they're providing care, there will be a dedicated floor for health engagement hub participants with simplified check-in, staff with lived experience and training specific to meet the needs of program participants. And again, Health Point is a FQHC that provides low barrier health care to underrepresented communities in South King County with an emphasis on outreach. Next slide.
So I don't know if we mentioned this, but the legislature did require that we identify a rural site and an urban site, hence why we have the parentheses, urban and rural. So quickly, I will go over our rural site. which was Blue Mountain Heart to Heart. They were selected. So Blue Mountain Heart to Heart has a long-standing history of serving people within their community in Walla Walla and throughout Southeast Washington. They were originally a legacy AIDS services organization, using Ryan White funds from the DOH office to support people living with HIV, to connect them to care, to get them virally suppressed, provide housing amid a cadre of other services. In addition to that, they are a syringe service program. They are also the contracted recovery navigator program within that region. They provide low barrier buprenorphine to their participants and have been for some time now. In addition to that, they've expanded beyond Walla Walla. As I briefly mentioned earlier, they serve a majority of Southeast Washington. They have 2 fixed locations, one in Walla Walla and one in Clarkston. And then they provide mobile services throughout Southeast Washington. And these mobile services are low barrier medical services, from vaccination to wound care to syringe service programming. In addition to that, there was a requirement that you provided access to methadone and buprenorphine. And so Blue Mountain Heart to Heart will also be providing direct transportation to their closest OTP for individuals who would like to start methadone as a form of opioid use disorder treatment. Next slide.
All right, so just to share a little bit more about where we're currently at, we're currently in the contracting process with both of the pilot sites that we just mentioned. And additionally to the site contracts, HCA is developing contracts for technical assistance and evaluation to help make these models sustainable and understand kind of what's working. So UW ADAI, in partnership with the She and Engage Clinic, we're working with to provide technical assistance and implementation support to our pilot sites, as well as our sister agency, Department of Social and Health Services, their Research and Data Analytics Division, to support an evaluation of outcomes for Health Engagement Hub participants. Additionally, we're working on developing a value-based payment model for health engagement hubs, and that VBP work is supported across several divisions at HCA, and eventually will involve consultation with our Medicaid managed care organizations. Per the RCW, HCA is required to develop payment structures for health engagement hubs, and eventually to direct Medicaid MCOs to adopt a value-based bundled payment method in contract with the hub. So that's something we'll share more about in coming times, and has really been a cross-divisional and cross-agency effort. I think that's it. Next slide.
So some of you may be wondering, what is a health engagement hub? We're talking all this meta, but we're going to spend a few minutes just getting in the weeds on what makes a health engagement hub. So first and foremost, it is low barrier access to physical and behavioral health. So we're talking about access to methadone and buprenorphine. We're talking about access to screening, testing, and treatment for infectious disease. That ranges from HIV, hepatitis C, to bacterial STIs, to any other infections that may be presented from the participant. In addition to that, low barrier primary care services. Primary care is a very broad and general term and can mean a lot of things, and is a large bucket of work. So this is to bring that in a very low barrier setting within the confines and the limitations of that program. Obviously, they won't be able to bring the whole suite of services, but they should be able to provide referrals and pathways to more advanced care. And then lastly, but not the least important, is behavioral health screening, referrals, and brief interventions for any mental health disorders that an individual may be experiencing. Additionally, harm reduction services are a core component of the health engagement hub model. Everything is supposed to be low barrier and meet the people where they are at, and provide access to risk reduction supplies for individuals who are actively using drugs. So we are talking about sterile syringes, injection alternatives, condoms, access to PrEP and or PEP, and drug checking services, and naloxone distribution. And also providing drop-in services. Some folks are not always ready to engage in a deeper level of care, and that's okay, but we should still be able to meet individuals' basic needs. So food, clothing, hygiene, just a drop-in space to chill, get out of the environment and relax and talk with a provider and have brief one-on-one emotional counseling. Next slide, please. So in addition to all that, we know not all the services can be provided within the brick and mortar sites of a health engagement hub. So there is also the component of navigation services. Navigation services will utilize peers with lived experience in addition to connecting folks to services not provided at the health engagement hub site. So we're talking about housing. We're talking about advanced diagnostics. If somebody needs to get an MRI complete or an X-ray complete, the navigation services will work with the MDs or the ARMPs on site to connect and facilitate those advanced diagnostics, in addition to any legal advocacy and then general emotional and social support. Relationships are foundational to this work, and so we really look at the navigation services and the peer work and building relationships with individuals as a foundational component. In addition to that, there are other services such as medication management for individuals who are prescribed medication for any chronic condition, providing trauma-informed care from beginning to end, from the front desk staff to the medical provider to the navigator, really focusing on trauma-informed care. And then also thinking about reproductive health and the importance of providing those services to individuals. Next slide, please.
So in the supplemental operating budget that was passed this March for state fiscal year 2025, we were appropriated an additional $3 million to expand health engagement hubs. And so that's on top of the initial $4 million that were appropriated for the 2 pilot sites that we just spoke about. So with those $3 million, 3 additional health engagement hub sites are to be operationalized in fiscal year 25. So we will consider initial responses from our November 2023 solicitation. As Tim mentioned earlier, we received a lot of interest and were able to fund every program that submitted a response to the request for interest. We'll prioritize geographic distribution across the state to ensure these services are equitably distributed, and programs led by Black, Indigenous, and people of color, including tribes. So an announcement about contracting plans is coming soon, and we do have a specific GovDelivery channel intended for health engagement hubs. So do ensure that you sign up for that on GovDelivery if you are interested in staying informed about that announcement and any forthcoming plans with health engagement hubs. Slide.
So what's next? There's a lot that is next, but we have 4 concrete steps. We are excited, and I'm sure Sarah Melfi-Klein is very excited. HCA has hired a dedicated health engagement hub program manager. In addition to that, we are looking to finalize all of our contracts. This has been a long process, but we want to make sure that all the details are correct. So that is the contracts with our 2 inaugural sites with Health Point Auburn, in addition to Blue Mountain Heart to Heart, and our work for research and evaluation with RDA, and our work around implementation and technical assistance support with the University of Washington. Shortly thereafter, we soon to announce plans to identify the 3 additional sites that were recently funded in the last budget, and then continued community engagement. So this is one form of community engagement, and we plan to build upon this. We know there's a lot of interested stakeholders in this effort, and so we find it important that we continue to engage the community, from governmental stakeholders to community to individuals with lived experience to community-based organizations, to answer questions and to build upon this model. So we're very excited about these next steps and continuing to build out this program. Slide. This is an opportunity for you all to ask any questions. If you don't feel like asking any questions during today's presentation, you can direct any questions regarding health engagement hubs to HCA Health Engagement Hubs at hca.wa.gov.
All right. There's one question in the chat from Brandy. Will we get these slides?
These slides will be available on the SURSAC SharePoint page.
All right. Thank you. All right. And next up, we have, let's see here, Kelly and Michelle, work group updates.
Thanks, Blake. We're just getting the slides pulled up now.
Of course.
Just gotta share, and then I'll be good.
I'll add my thanks to Michelle and Tim and, or Sarah and Tim. That was really a nice presentation. That's been a lot of work and a lot of mind melding and people coming together for many, many months to get that stood up. So thank you guys for that.
Okay, hello everybody. My name is Kelly Sandaker. I'm the SURSAC administrator, but I also help out with administrating the SEDISA and Safe Supply work group. And so we're just going to give a quick update from both those work groups. Both those work groups came out of the SURSAC committees. They came up with recommendations for these work groups, and now we're just going to give a brief update on how each of the work groups are doing. So SEDISA, substance use disorder intake screening and assessment. Meetings held twice a month for 90 minutes each. Today, meetings have focused on building shared understanding of the intake screening and assessment tools and process are currently required by state or federal mandate versus believed to be required or required on the agency organizational level. The work group has identified a need for awareness, training, and support to keep providers up to date on changes that support a more streamlined intake process, i.e. During one of the meetings, we spoke about the X waiver, and some people weren't aware the X waiver has gone away. It was removed. And people wanting more information on the ASAM 4th edition guidelines that are becoming. Mapping of challenges within the medical setting to community-based treatment referral process. This slideshow will also be on the SURSAC SharePoint page. And in this slideshow, we actually have the link to SEDISA's schedule and attendance link. So if any of you would like just to pop in to the SEDISA meeting and just see what's going on there, you can do so at your leisure. Safe Supply Work Group, meeting held March through June are held every other week and dedicated to learning, information, and gathering. We've had a few meetings to date, and so on 3/28, the group introduction, discussion of current hopes and concerns regarding Safe Supply. We do have a contractor that is helping out with that is doing the Safe Supply Work Group. I'm there in attendance at every meeting, and if they need any support from the HCA, then we're there. And HMA presented on 4/11 on safe supply research and potential models to explore. On 4/25, presentation from Dr. Paxson on Canada's Safe Supply Work Group. 4/25, meeting with Office of Community Voice and Empowerment to discuss strategies and opportunities for centering people who use drugs and have lost loved ones. Meetings held July through September will be held monthly and dedicated discussion to produce the final report. We will, and also here on the slideshow, there is a link here in which you can attend the schedule and attendance links. That is it for us. Is there any questions at this time?
Or if any of you have been on either or both of those committees, if you wanted to add your perspective, this might be a time to do that.
Any questions? Okay, let's move on. Thank you, by the way. Thank you for the presentation, Kelly and Michelle. And we'll move on to Scala Northwest presentation from Liz. Thanks, Liz.
Yeah, thank you.
Can we hear you, Liz?
Are you able to?
Yeah, I hear you now.
Right. With me and James. Make sure.
Are you able to hear me now? Okay. All right. Perfect. Sorry about that. Thank you so much. So my name is Liz Wilkin. I'm a registered nurse working at the Healthcare Authority. My background is in emergency department nursing, nursing education. I've also done about 20 years of all different kinds of harm reduction work and have lived experience with substance use disorder. And my role here at the Healthcare Authority is to support emergency departments initiating MOUD. So I'm going to talk about a new program that is coming out, the HCA ED Bridge program called Scala Northwest. For a little bit of program background, the initial direction for this program came from 5476. So in that bill, the Healthcare Authority was required to develop a position that would create, that would support emergency departments initiating medications for opioid use disorder and linking to care. The program received one-time state opioid response grant funding for startup and currently is funded by non-specific settlement funds assigned to HCA. So let's talk a little bit about why it's so important to have medications for opioid use disorder in the emergency department. The first is that patients with substance and opioid use disorder are, this is where they're at, right? 10 to 20% of ED patients have recently used illicit drugs, and that's the reported number. We can assume it's probably higher. People who use drugs are almost 5 times more likely to go to the emergency department than people who do not use drugs. And of the people who present to the emergency department, they're 7 times more likely to be admitted to the hospital, which means that when they go to the emergency department, they're sick, right? Like something is pretty wrong because they're so much more likely to be admitted. Oftentimes, the ED is the primary or only source of care for these patients, and so they may not have other instances where they're in front of a prescriber, someone who could initiate or provide medications for opioid use disorder. And so not only are these patients going to emergency departments, but they also have really high mortality rates after their visits. So in the 12 months following an ED visit for non-fatal overdose, the mortality rate is 5.5%. This is a 3.5 times higher mortality rate than patients who go for any other chief complaint. So for patients who go not for a non-fatal overdose. And that's if they leave at discharge. If they leave AMA, so if they leave kind of earlier than they're formally discharged, which often happens because patients are in severe withdrawal, their risk of mortality jumps to 7 times higher than general population emergency department visits. For patients who are admitted to the hospital, that mortality rate is even higher in the 12 months following discharge, and it goes up to 7.8%. So these numbers are, like, these rates of death following visits are comparable to someone who's going for a heart attack. However, the median age of death for this population is 39 years old. So these are young people who are dying. You can see here, there's this graph right here that shows along the bottom number of days since ED discharge and along the side number of deaths. And so, we're saying people have really high mortality rates for the year following the emergency department visit. But oftentimes, there might be, well, we don't need to start medications in the emergency department, right? We can link someone to care. They could follow up the next week. However, we can see here that amongst folks who died within 30 days of their ED visit, the majority died in those first couple of days, right? And so we can see how important it is to get these medications started at the time of presentation because some of the highest risk patients are dying immediately after the emergency department visit. We also know there's a lot of evidence that medications for opioid use disorder are effective in the emergency department and hospital setting. So just like in all other settings, right, MOUD lowers mortality rates rates by approximately 50%. But in addition to the impact on mortality and patient outcomes, there are benefits to this to healthcare systems, right? It decreases the rates of readmissions, of leaving against medical advice. Both patients and providers report more satisfaction, and it's recommended as best practice by national organizations, including the American College of Emergency Physicians. So we talked a little bit about how patients who could benefit from medications for opioid use disorder go to the emergency department. And I do think it's important to note that they are going to the emergency department more and more. So we can see that the numbers of emergency department visits related to opioids and opioid use disorder increased significantly between 2014 and 2017. And there's a lot of data that shows that those numbers increased again during COVID and afterwards. But we can also see that the rates of people getting treatment for illicit drug use is staying stable. So even though people are going to the EDs more, that's not leading to a greater increase in treatment. Which makes sense because treatment isn't being provided in the emergency departments as a general rule, as a standard. Other studies have shown that less than 9% of patients with a non-fatal overdose leave the emergency department with a prescription for buprenorphine. And those studies are looking at a wide range of hospitals and typically include like a large urban hospital or academic center that's bringing those numbers up. On other studies, the low end of buprenorphine prescribing is less than 1% of patients with a non-fatal overdose. For context, I think it's important to talk about like some of the other medications that we use every single time in the emergency department. We mentioned earlier that the mortality rate for these patients is similar to folks who come in with a heart attack, for example. And there's no instance where we don't treat a heart attack in the emergency department. That doesn't happen. If someone comes in having a heart attack, we are going to treat them, right? And there are certain medications that we kind of always use. So I want to talk about the number needed to treat. What this is the number of patients who need to receive a medication in order for one patient to benefit. And so when we look at aspirin for STEMI, and STEMI is a heart attack, we always give aspirin if we even suspect that someone could be having a heart attack. And for 42 patients that we give aspirin to, one patient will benefit. For blood thinners, for a blood clot, again, that's something that we kind of offer as a standard, and also something that blood thinners do have like significant risks associated with them, right? 17 people receive that medication for one person to benefit. However, for high-dose buprenorphine, the number of patients who need to receive the medication in order for one to benefit is 2. So these medications work. They work in this setting. For other medications, we don't need to have that high of a kind of impact or success rate in order for us to use them. And for other conditions with mortality rates like this, we always treat them. So in recognition of that gap and in following the direction of 5476, the Healthcare Authority has created a bridge program, Scala Northwest. And the creation of this program, kind of what we focused on was the identification of gaps from research and lit reviews, interviews with emergency department physicians across the state, and really looking to say, okay, what do we need to put in place to ensure that hospitals are able to do this work? And to make sure that all hospitals, right? Like the intention of 5476 was to create regionally distributed 24/7 low barrier equitable care. And so we wanted to make sure not to create a program that was really only accessible by urban hospitals or larger hospitals, but to create something that would centralize the kind of minimum elements required to reduce the burden as well as the cost to individual sites. So available to all Washington providers will be 24/7 access to a clinical consultation hotline, as well as practice guidelines and patient-facing information. For hospitals that choose to enroll in the program, we can provide technical assistance for implementation, support for staff education, and 24 scheduling for follow-up appointments, which is one of the biggest barriers for emergency departments, but also one of the highest risk for patients, because if someone has started on MOUD in the ED but doesn't have access to a follow-up appointment, that can actually put them at risk because it's a change in use pattern. So you change your use, you get started on MOUD, and then you aren't able to access a follow appointment. So you discontinue MOUD, return to use, and that's a risk factor for overdose death. So to talk a little bit about those elements, one thing that providers in the ED have said is, well, we don't know how to do this, or maybe it's not within our scope. And so the consultation line allows them to reach out to someone, put a note in the chart. It's 24/7, free to all callers. It's staffed by the University of Washington, and there have been recent trainings and expansion to include MOUD in the emergency department as a consultative specialty. Our website, which is going live next week, so slightly poor timing for this group, but is going live next week, and I'm happy to show you some previews of it if that's useful. But it'll have multiple on-demand resources because emergency department docs are really, really busy. They need to be able to plug something in right away, have it simple and accessible. We're including clinical guidelines. A lot has changed and is changing in kind of the era of fentanyl, and so there is kind of new recommendations, and providers don't always feel like they know what dose do I start at. What is the best way to initiate buprenorphine? How do I manage withdrawal? And so we'll have those available online. Also patient education, trainings and webinars, and then a low barrier service locator to ensure that hospitals can provide kind of relevant and accessible, as well as up-to-date referrals to services in the community. Technical assistance is something that's just readily available to hospitals who are looking for it. We can talk about implementing the program, scheduling, also, billing questions, regulatory questions, policy development, the identification of champions, kind of how to help support program uptake, and then, nursing and provider education. The scheduling line is 24/7, it's real time. So this is before the patient leaves the emergency department. Call the phone line, we'll do a couple screening questions, filter out results to make sure that the options are appropriate. We want multiple options per hospital so that the patient has a choice. Telehealth options, tribal health options, options that are going to be able to accept pregnant or pediatric patients. Calls will be about 5 minutes, and patients will get a date, time, and location for follow-up before they're discharged. This helps patients connect to follow-up care. They can get text reminders, they know where they're going, but it also helps providers who feel hesitant to start the medication and make sure that the bridge prescription, so the prescription the ED writes to get the patient from discharge to their follow-up appointment, is for the appropriate amount of time, because the provider knows when that follow-up appointment is, instead of saying, well, here's a 5-day script and the patient can't get an appointment for 7 days, right? So it kind of makes sure that we're able to bridge that gap. In order to create that scheduling service, we are looking at kind of building capacity. So a hospital lets us know that they want to enroll, they want to use the service, and then we go and recruit and enroll local follow-up options. So we're bringing in, some clinics are lots of different kinds of settings, primary care, family medicine, mobile clinics, and what we're asking for is recurring drop-in windows. So we're not connecting everybody's scheduling databases or EHRs. We're not asking people to hold appointments that could otherwise go to community members. We don't want to close access off, and we know that patients don't always follow up. So we ask for recurring drop-in windows when clinics can integrate someone into their scheduling, say, they have an admin day for their medical director, or they don't do intakes that day, whatever it is, where they feel like they could work someone in. That also keeps it low barrier for the patient, because it's not, if they're 15 minutes late, that's okay. They have this whole drop-in window. We've had a lot of clinics be really willing to move to offer drop-in windows when they haven't historically. Hopefully, again, increasing that low barrier capacity. And then we also are bringing in peer organizations that would like to be notified if the patient wants to opt into that, so that peers can reach out after discharge and before follow-up to help identify barriers and provide support. In order to enroll, we want it to be as easy as possible for hospitals and follow-up clinics. So there's no contracts, no financial exchange. They don't pay us, we don't pay them. No reporting requirements or volume requirements. And participation can end at any time for any reason. So part of this is to bring them in, but it's also to make sure we're accessible to smaller critical access and rural hospitals who can't necessarily like meet, oh, you have to do 10 patient a month guidelines that are often required for contracts for this type of program. Enrollment is really simple. It's just a kind of conversation and email with us, set up a meeting and talk about it. And we want to really support hospitals in whatever supports that work for them. If you don't need staff education, fine. If you do, great, right? Like, what does your hospital need? And follow-up clinics have control over what availability they offer and can always change it so that we can keep them engaged. We are collecting some data on the program. And so we'll look at the program impact by looking at the percent of emergency department, overdose, or opioid use disorder visits that result in the initiation of medications for opioid use disorder. Then we'll look at outcomes, so 30-day and 12-month outcomes for these patients, visits where they're started versus not started on MIUD, to see kind of mortality rates, readmissions, intersections with the criminal legal system. And we'll also be looking at a time trend of number of ED visits for opioid use disorder or overdose, the number of those visits that result in a start of medications for opioid use disorder, and then our rates of overdose deaths following ED visits. Some contact information here for our psychiatry line, information about Scala Northwest, and our upcoming website. And then I threw a bunch of numbers at you guys, so references for those studies so that you can review them. And that's an overview. Hopefully that kind of gives you guys enough information about the program or paints a picture. And I will put my information in the chat, or maybe this PowerPoint will be shared afterward and has that contact information, and I can pause there and hand it back over to you, Blake. I don't know if we're taking time for questions or not. I'll kind of follow your lead on that based on the agenda.
Yeah, we have any questions? We have time. Yeah, go ahead. Malika.
Hi, Liz. I was wondering, so you mentioned earlier that the high rate of death after discharge from the emergency room, and I know, did they keep track of what those cause of death, like what the cause of death was?
So those studies specifically are all-cause mortality, and so all-cause mortality is not specific to like overdose death. The reason that we look at all-cause mortality numbers for these visits is because that's how all other medical conditions are kind of evaluated. So when we're trying to compare mortality rates for opioid use disorder to mortality rates for a heart attack, for example, the direct comparison is all-cause mortality, because that's how we collect them for a heart attack. And I think the value of that is to be able to communicate to hospitals and emergency department providers, these patients are sick, they are having an emergency. Other medical conditions with these mortality rates are ones that you always treat. Does that make sense? Like why we focus on that all-cause mortality? So that's what those numbers represent.
Yes, I mean, actually, but I'm just hoping that it doesn't become the situation like, okay, well, you use drugs, so we're just going to put you on, a high dose Suboxone and then kick you out the door. Like, people have like a lot of things. Most of the people that I know that have died after they left the emergency room was not related to overdose. When they went there because something was really wrong with them, it was sepsis. It was, like all manner of other things. And they oftentimes don't get treated well and they get kicked loose. So I'm just wondering, is there something that's going to happen that will make sure that we don't end up with like what we do in this country where we, like if you're a woman and you're pregnant, that's the only time you get comprehensive health care in your entire life, right? Like if you're a person that's experiencing SUD, they're gonna pay super attention to getting you on MOUD, but everything else that is wrong with your body because of, the hardships that you've been experiencing is just not going to be paid attention to, so
Yeah.
that's a comment. It's not directed towards you. It's just towards the whole project in general that we would make sure that we're treating whole person health, not just one piece of it.
Yeah, absolutely. And I think a couple things in response to that is, one, we do know that people who are started on MOUD have better health outcomes and higher engagement in other types of healthcare, hopefully kind of addressing those things. Also, absolutely, emergency departments often don't look at or believe people with opioid use disorder and miss really significant clinical presentations. And that's a really serious issue. They also don't typically start on MOUD. And there's a lot of studies that if providers start using MOUD for patients with opioid use disorder, they then like instead of reducing stigma and then offering MOUD, the act of offering MOUD shows that providers then have more positive beliefs around this population, are more likely to believe that they are telling the truth, that OUD is treatable and not a moral failing. They're more interested in learning about MOUD as well as opioid use disorder. And so hopefully, like those studies would kind of indicate that if ER docs start doing MOUD, their attitudes towards the population shift. Hopefully they're then seeing some of those underlying conditions. But absolutely, that is a huge concern. And thank you for sharing it and bringing it up because it's so important.
Thank you for your answer. It was really thoughtful. Thanks.
We also had another question about a flyer. Liz, see that in the chat? Is there a printable flyer that can be distributed?
Yes, absolutely. Sorry, I was trying to find it in the chat. I will take a look at the chat after this.
Yeah.
But yes, I do have a flyer to share with
Perfect.
emergency department providers. And if it's okay, I'll send that and the slides to the organizers of this meeting who can maybe share it with the group. And I will share the contact information slide again.
Awesome. And we have that information in the chat as well.
Oh, okay.
All right. Thank you, Liz.
Mm-hmm.
All right. Next up, Cameron, RMP highlight. Greater Columbia.
Hi, good morning, everybody. Permission to share my screen, please.
Please.
It looks like it's not remove this showing up for my slides though. There we go. Now it is. Can everybody see that and hear me okay?
Roger that. We've got you.
All right. So again, everyone, I'm Cameron Fordmeyer. I'm the Regional Administrator for the Recovery Navigator Program with Greater Columbia Behavioral Health Administrative Service Organization. I have some co-presenters here with me today. So Lindsay Kennard with Quality Behavioral Health. She's the Program Manager for Asotin and Garfield. Shireen Hunt, who's the Executive Director with Merit and also Program Manager for Benton Franklin teams. And then Melissa Denner, who is the Program Manager for the Kittitas and Yakima teams. So here is the 10 ASOs and their regions. You can see we are the one on the bottom there in the yellow. So we are the largest geographical area, not the largest populated, but we cover quite a wide array of areas that have their own unique strengths and challenges. And so we try to be very flexible to meet each need of those communities and their community members. So again, our areas cover from Kittitas, Yakima, Benton and Franklin, Walla Walla, Columbia, Asotin, Garfield, and Whitman counties. So just some little bit of info on how we structured our teams before we get into some of the unique things that each team has been doing. We funded fully 7 teams that cover those 9 county regions. And so some teams will cover multiple regions as well as one program manager covering multiple counties and multiple teams depending on that region's size. So each one of those 7 teams consists of 4 individuals with live life experience that perform the outreach and case management duties. We have one program manager that will supervise a team, help coordinate with community partners, the key stakeholders, and facilitate those policy coordinating groups and operational work groups. And one of the unique things that we were able to do is develop a specific position for diversion coordinator. That person will be 100% solely involved with the criminal justice system. They will work directly with the courts and any correctional facilities so that if there's pre-arrest and pre-trial diversion, we're not compromising the rapport building that the team has done and not looked at kind of as a, dangle the carrot and do what I say, even though we are all accepting of everything. So we didn't want to compromise the live life experience individuals that do the outreach and case management, and all the hard work they've done to do that. And so one of the unique things Shereen will talk about is we've been doing pre-trial diversion since January 1st of this year. So I believe we were one of the first Recovery Navigator programs to start doing that. And we're looking to roll that out to the surrounding counties and then also starting up pre-arrest. So one of the ways we're able to be successful is we have client care cost in addition to fully funding those teams. And so we try to be very flexible with engagement, relationship building, and any barriers to treatment. So some of the things we've used our funds for have been treatment, housing, any type of transportation, clothing or work attire for either retraining or any type of education stuff, food, basic needs, of course. And then some of the areas that we use those funds are for assistance with animals. So we've had individuals who were hesitant to go to treatment or hesitant to engage in any type of rapport building due to leaving their animals. And so we were able to provide boarding or shots, for example, anything like that. So just some basic on how we structure that before I turn that over to Lindsay. Hi, Lindsay, you there? If you want to work on that, Lindsay, we'll hop over to Shereen real quick and I'll just come back to yours if you want. Hop over to Shereen.
All right. Good morning, everyone. Thanks for having us. Can everybody hear me? Okay, fabulous. So this is a picture. Governor Inslee came to visit our Kennewick office late last year, and we were thrilled to have him to come to our outpatient facility to talk about some of the great work that we're doing in the Tri-Cities area. In this picture, we've got criminal justice, we've got our chief of police, we've got our treatment staff, we've got some of our board of directors, we've got our Recovery Navigator peers and program managers. So that was a thrill to be able to share some of our success stories with the governor. So we started in Benton and Franklin counties in October. Another provider had the contract, and we were asked to come in and take over that contract October 1. These numbers are a little bit dated because we've had a whole lot more referrals since then. But as of February 26th, Merritt had received 79 pretrial diversion referrals from Benton County District Court and opted them into the Recovery Navigator program. Out of the 79 referrals, 6 individuals signed pretrial diversion court orders. So those were just kind of official court orders. And the other individuals were actually opted into pretrial, but there wasn't just the standard court order signed. It was just an agreement with the prosecutor, defense attorney, and the judge that they would be referred to the Recovery Navigator program peers for pretrial diversion without the official court order signed. Merritt received 2 pretrial diversion referrals from Franklin County District Court at that time. At that time, we hadn't really gotten into the court systems. As of today, we are in Pasco Municipal Court providing those services and in the Franklin County Jail. Merritt also receives many social referrals in both of these counties. So how we've set this up, it's been pretty fabulous working with our partners, our law enforcement partners, our criminal justice partners, our other community partners, to set up these pretrial diversions. So the court clerk sends the docket to our Recovery Navigator peer email each morning. Our Recovery Navigator peers are in the courtroom and actually in custody and out of custody court to engage in person. We've gotten to know our judges and our attorneys really, really well. And they will say, hey, there's a Recovery Navigator peer here. Would you like to go speak with them and talk about this pretrial diversion? So we've had some great engagement right in the courtroom. And then also our Recovery Navigators are in the jails to meet with in custody and out of custody individuals. Our Recovery Navigator peers, with their lived experience, they're able to connect with those individuals, right? And give them some hope. I think that's probably the biggest advantage of our peers with the lived experience, to say, hey, I've experienced this. This is what worked for me. I want to help you. How can I walk with you through this process for you to get into recovery? And is this something you're interested in? So they opt into the Recovery Navigator program. There's just some real simple intake packet, consent, and a multi-party release to begin that intensive case management. So we've worked really, really hard to build that relationship, especially with the prosecutor's office. Prosecutors are really the gatekeeper for any pretrial diversion, therapeutic court admissions. And so I'm just really happy to say it's been a pleasure to work with all of those individuals. I've also worked with the commander of the Franklin County Jail in figuring out, when's a good time for our peers to come into the jail to meet with these individuals? When's a good time for our substance use disorder professional, who's our diversion court coordinator, to come in and do an SUD assessment? So, in the peers talking with those individuals, they're asking them, are you interested in treatment? Are you interested in, getting an SUD assessment? Are you interested in, what our plan we can work on together with, once you leave incarceration? Or for those people that are released from custody, how do we get them connected to a safe place to go? A lot of our peers are transporting people at the time they are released from custody, and they may be able to transport them to a respite program, which they can stay up to 7 days. We've also worked really close with our housing partners, our recovery residences, our Oxford houses, to possibly couch those people for a couple of days while they're waiting maybe for their residential inpatient bed date, or while we're getting them connected to MOUD services. Those kinds of things. So just really working on, meeting the individual where they're at, giving them some hope, helping them to gain some understanding of, yes, you can do this. So it's been pretty amazing. I'm super proud of our Recovery Navigator peers. I'm just super proud of the work we've done with all of these partners coming together, because I've had a lot of years in the field, and I think our therapeutic courts work so well because there's a team approach, right? There's all of these stakeholders, all of these people at the table communicating, how can we best serve this individual? And that's really been amazing to see with the pretrial diversion and this Recovery Navigator program. Oh, supervision. Let me talk about that a little bit before we move on. Thanks. So as a behavioral health agency, we have very experienced SUD approved supervisors, both SUD and mental health approved supervisors that are working closely with our peers. So our peers are not out there alone trying to figure out, how do I maneuver this? How do I manage this? Our peers have direct supervision from myself, from Melissa Dinner, from their other colleagues that are working within our agency. They're able to call us at any time with questions. We do the policy coordinating group with our stakeholders, and then our operational work groups where we're staffing these cases and really helping to take a look at the challenges and solutions and what's going to best serve that individual. So I wanted to highlight a little bit about supervision as well. And then transportation. So we've had some success in connecting with other Recovery Navigator peers throughout the state. Because how do we get somebody from, for example, Kennewick to Wenatchee to go to their residential bed date. We used to rely on the Greyhound bus system. That's not reliable anymore. It rarely works. And so that's pretty frustrating. So we have had some great success in connecting with other Recovery Navigator peers. So we meet them halfway. So an individual gets released from custody. They may go into the respite center for a couple of days until they can get their bed date. We transport them from the respite center, the halfway mark, to the residential, and then the Recovery Navigator program peer from that county picks them up halfway and takes them the rest of the way to the residential treatment center. So just trying to figure out creative ways. How do we, because transportation is a huge barrier. We're rural, and how do we get people from point A to point B successfully? Because we know that if we don't engage them quickly, that window of opportunity is going to close, and that individual may not be ready tomorrow or next week, or we may lose them out there. So keeping them engaged, getting all those community partner connections has just been pretty amazing.
Do you want me to go next, Cameron?
Yes, please. We'll wait for Lindsay to come back on and we'll go back if we can.
Okay. Oh, hi, everyone. My name is Melissa Denner. I'm a licensed mental health counselor and a substance use disorder professional. I work at Merit Resource Services, and I'm the program manager for the Kittitas and Yakima counties. We signed the contract for these two counties on December 11th, 2021. And we hired our first Recovery Navigator peer on January 14th, 2022. And we sort of launched our community-based case management services kind of mid-late May of 2022, after kind of establishing our PCG, Policy Coordinating Group, and Operational Work Group, the OWG. So I just wanted to, I don't know how familiar people are with our counties. So they're both Kittitas and Yakima are considered rural counties. Kittitas sometimes is called a frontier. So Kittitas, although it is a pretty large geographical area, it has fewer people, lower population than Yakima County, and a little bit more of a small town feel to it probably. Yakima is quite diverse, I think, in the sense that there's kind of like the city of Yakima, and then there's the Yakima Nation and kind of Toppenish, Wapato. And then there's like what we call the Lower Valley, Sunnyside, Granger, Grandview, with a pretty high monolingual speaking, Spanish speaking population. I think another important thing for us to know related to substance use disorder and just the needs in our communities is that Yakima has a pretty high crime rate, and we have, gang activity, pretty high homelessness, and we are a major drug trafficking hub of the Pacific Northwest, and have been since I've been knowing Yakima since the 80s, I guess. But and then I just want to talk a little bit about our staff. These are some pictures of our staff that you're seeing on here. So all of our staff have lived experience with substance use disorder, and as well as a minimum of 12 months or more of continuous sobriety, and they're actively maintaining stable, healthy recovery. They all are registered with the Department of Health with their agency affiliate, and they're trained through the Healthcare Authority as certified peers. As Shireen mentioned, they're all supervised by, approved supervisor or clinician. They all follow our agency policy and procedures, just like all of our staff do. We have weekly team meetings, and we provide individual supervision when needed or when requested. And our staff, our Recovery Navigator peers, always have access to us. There's always supervisory coverage for them at all times. We also have a lead Recovery Navigator. This person is kind of the daily support and go-to for all the other Recovery Navigators. On this picture is in the lower is the Kittitas County, and the upper is the Yakima County Piers, and in the middle is our Recovery Navigator House. That's here in Kittitas County, and no one lives there. It's an office for the Recovery Navigator Piers, but we do have people that, participants that drop in and play Uno and put puzzles together and have snacks and connect with the Recovery Navigator Peers. And we're super happy about having it. So our community partners, we have a lot, but local law enforcement, this is, both counties, local law enforcement, therapeutic courts, Department of Corrections, the jails, probation, district probation, U.S. federal probation, pretrial services. We're very connected to Oxford and Recovery Residence Houses, the 12-step community, harm reduction programs, our local ER, and other community care coordinators and peers. We have a lot of community word of mouth, and also just our current and previous participants refer people to us all the time, which is kind of cool. On the screen, you'll just see these are, we also have notebooks in each county with letters from our participants sharing their success stories. And so these are just some little quotes that our lead picked out to add to the PowerPoint here. We do jail reentry services in both Kittitas and Yakima for the peers meet with interested incarcerated individuals, engage them in the Recovery Navigator program during their incarceration to support safe and successful transition back into the community. This can include scheduling an SUD assessment while they're still incarcerated, arranging with the SUDP, diversion court coordinator, transportation to inpatient, as Shireen was talking about, or to stable, sober housing, meet them there, pick them up straight from release, get them kind of some basic needs and just some support and some hope. Some of the services we help with are, getting people to detox, either social or medical, getting them SUD assessments and, a level of care recommendation, inpatient, intensive outpatient, mental health services, connected to the recovery community, entering sober housing or other transitional and stable housing, help them get back on their Medicaid, lots of people going to the doctor and the dentist, and different types of transportation, bus passes, bicycles, getting a battery for their car so they have a working car, helping them with educational and employment goals. There's just so many things we do, as Cameron talked about earlier, kind of that creative, flexible way of helping people in their recovery and breaking down barriers to treatment. So I could go on and on, but those are kind of some of the main highlights, I guess. The peers, by meeting participants where they are and sharing their personal lived experience, the Recovery Navigator peers just provide ongoing support and encouragement while teaching life skills, modeling self-advocacy, and giving hope to the participants. I want to highlight some successes. So I talked a little bit about the RMP house. I talked a little bit about our notebooks. We were able to make copies and give those to Governor Inslee when he visited. Something that I really think is powerful is that, we have many participants, not a couple, not a few, not several. We have many participants who have come through the Recovery Navigator program, entered into some type of substance use disorder treatment, and today they have anywhere from, 9, 12, 15 months to 24, 28 months of continuous sobriety. And for them, that is an abstinence-based, other than prescribed medications. That's how they identify their recovery. And they're active in the recovery community. They're living without shame. They're building, a life that's meaningful to them. And I just think that that's at the heart of everything, the most powerful thing. We recently had an event. So in Yakima County, we had 4 of our Recovery Navigator participants, some of which are in our success story notebooks, and they presented to probation, corrections, law enforcement, prosecutors, the different criminal justice system and law enforcement and stuff. And it was just very powerful. We've gotten a lot of feedback since that event where law enforcement has contacted us and said, please keep doing that. They were really moved. One of the detectives, one of the presenters, the detective, had personal experience with. We just got really positive feedback. All of those people on that panel had between a year to 2 years of continuous stable recovery. One of them was celebrating, I won't give the birthday anyway. And then we also in Kittitas County had a panel present to the Ellensburg Police Department, and they do an in-service day. And so the captain reached out to me a few weeks back and told me, like, at the end of the in-service day, so all the community partners go and present to law enforcement over a couple of weeks period of time. So like all the other nonprofits, all the other community-based healthcare, all the programs in our community. And when the officers gave their feedback on the survey, the thing that they liked the most and felt was the most significant and powerful was the presentation from the people with lived experience in recovery. We met Governor Inslee. We've been in the local news. Shireen has been interviewed. Our lead RMP was interviewed. 2 participants were interviewed by the news. We've been in the local papers a few different times. Currently, we're fully staffed, so we're up to 4 in each county now, just recently hired. And we just recently hired a diversion coordinator to cover Yakima and Kittitas. And we hope to develop and implement a Recovery Navigator diversion program following in Shireen's footsteps. And those are our success stories. I don't know if people read them. The Recovery Navigator,
Sorry, I can go back.
The Recovery Navigator program is crucial to me and my recovery. They gave motivation and hope. And the best part about it is they didn't give up. Without this help, no doubt in my mind, I would be out drinking and looking for dope. The Recovery Navigator team took me to Walmart and filled my fridge. When I got out of treatment, I had nothing. I just ate and filled my belly. I'm truly grateful. Thank you from the bottom of my heart. Thank you for saving my life. The compassion, friendship, and guidance has been nothing short of amazing. If I wasn't in the Recovery Navigator program today, I would be on the streets lying, conning, cheating people, or in jail or dead. Today, I feel great and have something to live for. I owe it to the Recovery Navigator program. I'm thankful for where I am at in my recovery journey, and I owe the Recovery Navigators for providing support through this journey. I feel seen by the Recovery Navigators and know if there is an issue, they will be there to support me through it. Thank you.
Thanks, Melissa. I want to second that. I was at the April 30th meeting that Melissa was talking about, where her individuals and participants in the program got to speak. And I've worked in behavioral health for 24 years now, 11 of that in direct care and crisis and diversion services. And then the rest has been in leadership, where when you are in the system and you're working with people on potentially their worst day of their life, or you're fielding complaints, it's really hard to see the good that you're doing. And so, especially from a correctional standpoint as well, and to hear the impact that this program has had on people, and to hear how thankful and how they're living productive lives, it was very empowering, and it was very, reestablishing that purpose, and hopefully getting away any jadedness that the system kind of brings into you when you just get to see kind of all the muck of it. And so it was awesome turnout, great job by your team. It was really nice to hear all the good that's being done in those communities. Hi, Lindsay, are you back, and can we hear you?
Yeah, can you hear me?
I can, thank you.
Oh, good. Okay, thank you. Sorry about that earlier. All right, well, I'm Lindsay Cannard, and I am the program manager in Asotin and Garfield counties. But today I will be talking about Asotin County. So this picture here is our policy coordinating group in Asotin County. This was taken in 2022, maybe halfway through the year or something. So it's an older photo, and the stats on the side there are also from the end of last year. So things are a little bit different at present. So the impact of the Recovery Navigator program in our community has been huge. This is the first type of alternative response in our area. And RNP came into the game at a time when many of our first responder systems were understaffed. For law enforcement and first responders to have RNP staff available and ready to respond when called has been incredibly impactful in ways including increasing public safety by being able to provide resources and time. So when someone has an interaction with law enforcement and RNP is of interest to that person and a referral is made, they call us because we can take the time to spend with that person that law enforcement oftentimes can't. So then it frees law enforcement up to continue to respond quickly to other incoming calls that might be more appropriate for a law enforcement response. Being funded by the state and having the flexibility that our program has really benefited participants, staff, partners, and the community at large. We've been able to help people in ways that other programs or providers simply cannot. We've purchased things that have helped stabilize and improve the quality of life for the people that we're working with. We've purchased things like welding helmets, school books, driver's license exams, clothes, winter boots, warming items, prescriptions, tires, car parts, haircuts, and on and on. We've also been able to lean on GCBH to help find funding for inpatient treatment when someone doesn't have the insurance coverage due to Medicare. The flexible funding has and continues to save and improve lives, thereby improving the overall health of the community. We are also able to allow staff to provide intensive case management in the field, meaning they can spend the hours needed with the participant and see them at a frequency that is individualized. So not having to bill an insurance provider frees them up to really show up and walk with participants. The flexibility in funding also provides our systems with viable options for assistance where they may have not had any options in the past. So this is just an example. A call came from dispatch where a person had just been released from jail and they were very upset and causing a disturbance outside of the police department. They didn't have anywhere to go and they didn't have shoes on their feet. So RNP was called and we were able to sit with that person and figure out a safe place for them to go and literally put shoes on their feet and help them on their way. So this not only helped that individual, but also the police department and the jail. Go to the next slide, please. Our focus on relationships and creating space for people to be heard has helped bring people to the table, regardless of differences. There's opportunity to find common ground and work together. We approach our work with a non-judgmental attitude, a focus on connection, and a mindset of problem solving. And this applies to myself as program manager, as well as my staff working as outreach coordinators and case managers. So we do this in the way we work with participants and community partners. As a clinical manager, I have structured weekly supervision with each of my staff, and we have a weekly team staffing. However, supervising and supporting peers in the challenging and complex work they do is a daily endeavor. They are well trained and participate in continuing learning and education. They are brainstorming and finding creative solutions to all kinds of complex problems and are practiced and comfortable coming to their supervisor to staff situations. We also at our agency have access to a multitude of expertise. Our clinical director, crisis program manager, mental health program manager, and really any other member of management are accessible and valuable tools for staff. We have the access and ability to provide warm handoffs to more appropriately credentialed staff when RNP may have something outside of their scope. At our agency, we really value and prioritize teamwork. For example, within the last year, we've had to move our designated crisis responders to telehealth due to staffing shortages. And during this time, my staff were continuing to respond to referrals out in the community, some of which were directly crisis related. And we've been able to assist individuals and community partners by helping get people to the hospital for evaluation when needed, being able to sit with that person and advocate for them and wait with them while they're medically cleared and be by their side when a DCR responds for an evaluation. This has really been an asset to so many. Our RNP has been an asset to helping our systems and reducing harm and increasing public safety. We were able to help law enforcement in November with a mitigation site and help provide people living there with warming items that literally saved their lives over the winter. When the site had to close several months later, RNP was able to help connect with people and relay important information from the city and help folks leave the site without confrontation or any trespass citations being issued. And there were approximately 80 people living at this site. Although our community is struggling with lack of housing and no shelters, because of the relationships that have been built, we continue to have focused community meetings, bringing multiple jurisdictions together to work on solutions. It has been said by our county prosecutor that the Recovery Navigator program is the bridge that connects participants and community partners. So really bringing that element of relationships back to the center of our work. That is it for me. Thank you very much.
Thank you, Lindsay, and thanks for overcoming technical difficulties and coming back in time. Again, some of our counties that we're serving have absolutely no therapeutic courts and no diversion services, so RNP is it. So I'm extremely proud of the work these teams have been able to do in reaching people in unique situations and getting the help that they need and their communities deserve. So I think we could open it up to any questions, or if time permits. I don't know how we're doing on time.
We are doing fine on time.
All right. So any questions, comments, concerns? We'll open it up to the team or myself. Letting us off easy.
Cameron, there's quite a bit of comments in the chat. I think Rep Davis was giving some feedback throughout how pleased she was. The investments are showing the impacts that they're having. So I hope you're able to see them.
Thank you.
All right. Any questions for the group? Thank you. Great presentations. Appreciate it. Okay. No more questions. We'll move on to the next agenda item. Again, thank you so much for the presentation. All right, walk-on items. James, we got about 5 minutes by the agenda, or maybe a little bit more than that, to talk about, I believe it was an event that you wanted to talk about. So please.
Thank you so much, Blake. Peers Empower Peers is a local nonprofit that specializes in education for peer support. And this year's annual conference is entitled It Takes a Village. It'll be in Spokane, Washington, at the Spokane Central Library. The Central Library is the host of Community Court here locally. And our keynote speaker is going to be Officer Plunkett, who partners and specializes with the RNP program here locally. What's unique about this event is instead of just being our traditional workshops, we've incorporated a resource fair and some direct service for individuals experiencing homelessness. It's all about building community. It's a free event for anyone to attend. We'll have success stories, resources. Peer Respite will be there presenting on what they're doing in our community. We'll have family resources and then recovery resources. There'll be a free lunch, a makeover room with haircuts and a clothing bank, self-care room, and just a big event for the whole community to come together and kind of combat stigma when it comes to mental health and addiction services. But it's June 1st from 10 to 3:30, and it's at the Spokane Central Library.
right, thank you so much. Any questions, James, about that? All right, sounds great. Thank you, James. All right, yes.
Sorry, I'm gonna go off scripture. Thank you, James. That was really nice to hear about your event. I want to come back to camera for just a moment as we talk about the region. And just a question I have, Cameron, is about your capacity. Can you say a word or two about whether you're able to, in pretty good time, address those to come forward? Or are there areas where you're finding capacity issues are getting limited? Can you just say a little bit about that across your region?
Sure. We are doing a good job of prioritizing and moving people around from case management to outreach to avoid that. And so the one thing that we did adjust from the traditional model to help with that capacity is make the diversion coordinator position, so that relieves some of the work that the outreach and case management teams are doing, to where when we do have pre-arrest and pre-diversion, that individual can take point on those and provide either an SUD assessment right there in the jail, or kind of a work with that individual on stabilization and getting their assessments and placements done, and then a transition to the team, so that there's flexibility there, that we're not overburdening everybody or increasing caseloads to the point where the compromising the treatment. So we're able to do some unique things, and sometimes that staffing, like Lindsay talked about and Shereen talked about, to make sure that if there are people who are needing more attention, that we're cycling people back from intensive case management to maybe more of where we can monitor them, or even refer to existing programs that are already there to assist.
Thank you.
You're welcome.
Okay, Kelly, then we'll kick it back to you to review the June agenda.
Okay, we'll do right now. Remember, this is just a draft for right now. Do I just go over each item?
Yeah, just
okay. So for right now, we have the normal stuff: the welcome, the public comment, walk-on items. This Islamic model will be shared as well. The RMP report by Brianna Pearson will also be shared. We're going to have the North Sound BHASO come in to speak on the RMP stuff, and then any walk-on items and review July's agenda. Any questions about the draft so far?
As usual, the agenda will be sent out as well for feedback before finalizing.
Say that there's for the presenters today, thank you. That was really good. A lot of heavy content and good content. And I hope folks are able to take the information in. The contact information is there. Sometimes you come to these meetings, you hear this information, you go back and come up with questions. So feel free to send those in. I would say, just in recap, that there's a lot of presentations. And so we also want to hear from the committee on discussions that you'd like to have. We can bring the presentations forward that you're interested in, but then what kind of dialogue or community or committee discussion you want to have, and feature as well. So we can pick a topic and just kind of open it up to the committee to share their experience or their questions of one another, and that type of thing as well. But thank you, Kelly, for putting a great agenda together, and for all of you that contributed. I know I learned a lot today, so appreciate it.
Okay, should we get some time back?
Unless we have other comments here at the end. Yes. Oh, somebody's up.
Jason.
Yeah, I just wanted to take a second. Michael, It's been a pleasure working with you over the years. Your dedication, your drive to the recovery community, to recovery housing as a whole. We've come a long way in recovery housing. We're well over 500 homes in Washington State, and a lot of that wouldn't be possible without Michael and his assistance. You'll be missed. I wish you the best in your recovery, and thanks for all your support over the years.
Thank you, Jason. Really appreciate all the work. And it is very heartening to see the number of homes in the state and how that's grown over the years. It's just each one of those homes, you know, it's life-changing for folks coming in and out. So thank you for your leadership and contribution. Appreciate the comment.
Absolutely.
All right, Michael, this is your last meeting. You want to take us out?
Yeah, just a ton of gratitude, and please keep the active listening, bring in diverse opinions, and keep moving forward with your recommendations. It's wonderful to see the evolution of support in the community. And I think that the Greater Columbia was a great example of that today, just hearing county to county, community by community, how people are getting the support that they need. So thank you all. It's been a great opportunity for myself to learn. So thank you. Thanks, Mike.
Anything else, Kelly?
Yeah, there's some recommendations for future items in there, Blake, that we'll take back for consideration. So.
Okay. All right, folks. Thanks for your time, and we will see you next month.